So R2C stands for Ready to Change, and it's because the original intervention is addressing motivation to deal with substance use issues. And we wanted it to be called Ready to Change because in the telephone environment, particularly where it's implemented here at HealthLink, most of the callers are actually opportunistic callers ringing up to touch base with the service system, and they're not necessarily treatment ready that we might see a couple of years down the track after being in and out of our treatment system a few times. So we wanted it to purposefully be marketed in a way to the client group as something that was the first foray into treatment, so it's a gentle introduction to treatment whether they're ready to change or not, rather than reducing your alcohol use or something like that. Yeah. Any other questions or queries? No? Okay, I'll kick on. You might have more as we go. Okay, so just a little bit about telephone delivered treatment really, because Ready to Change is something that was developed for the telephone environment, and it was kind of a neat opportunity. We used it in a face-to-face environment as well, and it is used in face-to-face, but the best part about it being developed for a telephone environment is we had to pay a lot of attention to the implementation challenges of delivering evidence-based practice that you could usually assume in a face-to-face setting would be handled by the clinicians and their own clinical competence really. In a telephone environment, we had to actually send the resources to the client so that we had an assumption that what the clinician on the telephone was talking about was also what the client themselves were also adhering to. So because of that, we paid a lot of attention to the materials that we developed for Ready to Change so that they were equally understood by clients who wouldn't, and clinicians who wouldn't have all the non-verbal cues that you might have while you're sitting in a room together. And I'll talk to you a little bit more about that, but one of the reasons why it was indicated that this type of intervention, which is only 6 sessions in the telephone environment, was something really worthwhile to pursue, is just because we know that people who access treatment via online or telephone settings are not necessarily the same type of client that walk in through the front door at an alcohol and drug treatment setting. And so we wanted to provide an opportunity to broaden the scope of treatment for alcohol and drug related issues. So what I guess I'm saying there is, in the strictest sense, we wanted to make this treatment as accessible as possible to anybody, and particularly people who would perceive that walking into a drug treatment setting would be stigmatising, or they worked full time, for example, or were in the care of children full time. Hiya, how you going, Celia? So that they had access to treatment over the telephone. So we know that treatment seeking is really, really low in our general population for all alcohol and drug related issues. And we know that the telephone sort of environment overcomes a lot of those barriers to treatment. But we also know that a telephone delivered treatment is not really appropriate for people with complex psychosocial needs. So really we were looking at people in this top tier of the demand model that was really of low to moderate risk of harm associated with the alcohol and drug use issue. And it just took a few pilots and a few years of setting up appropriate screening and governance processes for us to target this particular group appropriately. So that the clinicians on the telephone were not managing really, really significant risk or really significant psychosocial complexity without the backing of a service. Because while you're on the phones, I think holding that risk is a little bit more difficult. So it's really just this low to moderate risk that is more appropriate for a briefer intervention, a 6-session intervention that could be delivered over the telephone. That was the remit. In the development of R2C, we also acknowledged that this was an opportunity to develop something that could be used in face-to-face settings as well. So what we also included in a lot of these materials are other resources that could be used with the more complex patient group, basically. So we tried to sort of address both of those client groups. The first evaluation pilot was what informed the changes that we made to our intervention. I won't go into heaps of detail about it, but basically this was the first foray that we had into a structured intervention delivered over the telephone, and we tried the usual kind of strategy of having 6 quite planned sessions for the clinicians to deliver, and we evaluated it in terms of just a case file audit of 30 clients. Interestingly, we found that it worked really quite well. We had a 4-week follow-up telephone interview as well that we gave, and we got qualitative feedback from the staff and the clients. So it was very much a feasibility pilot and a pilot of the acceptability of the materials. And we found that in actual fact the screening tools we gave them, like the audit and the K6, significantly reduced after they received the first iteration of R2C, which was called PACT, but that when we got the qualitative feedback from the clients and the clinicians delivering it, it was cumbersome, it was difficult to deliver, the clients found the materials hard to understand. The adherence measures we were interested in was really looking at in a case file audit the number of worksheets that the clients had actually done, and they really hadn't done many at all. And the only worksheets that they really adhered to were the ones that we had included, which were based on a particular principle around node link mapping and using just mapping to communicate core concepts with people. So this is the sort of feedback that, we were really actually quite surprised about the impact on alcohol use outcomes. This was only for people who had difficulties with alcohol, this initial pilot. We were quite surprised about that, but we, as part of the development of this intervention, we were really interested in how to make it better and how to improve it. So we took on board a lot of that feedback and rewrote the intervention entirely, basically, and that's when Angela and I were given a full remit to be able to do something that would be more easily translatable into our clinical settings. So we revised everything on the basis of this initial pilot. All of the exercises that we had in there were converted into a map, because that was really the only worksheets that our clients seemed to adhere to. When I talk about adherence, really it's not about whether people are following the rules. There's a lot of evidence to show that any practice that a client engages in between a session with a clinician and the next session is one of the biggest predictors of improved outcomes. So it's incredibly important in clinical work that it's not an isolated conversation that you might have in a counselling sense with someone that then isn't integrated into their day-to-day life. And this day-to-day practice is why we do like exercise sheets, or we ask them to reflect throughout the week on a particular skill that we'd like them to acquire. And the integration of these new skills into their day-to-day environments is what is identified with long-term behaviour change. And this is across all behaviour change literature, not just in addiction. So when I'm saying adherence, I'm not talking about whether they did what they were told to do as part of the program. I'm talking about something that is one of the strongest predictors of good treatment outcomes, okay? We took a transdiagnostic approach when we rewrote the intervention, because initially we were funded to develop something just for alcohol. And as practitioners, we knew that rarely would we just have someone present with one drug use issue. And particularly coming from a transdiagnostic perspective, which is an area of research that I'm very interested in, transdiagnostic approaches are addressing some of the implementation challenges that occur when you just develop materials for one drug, because that client doesn't really exist. The one person who only uses alcohol would be a very small minority of the people who seek treatment in our system. They exist within the broader population, but they are not treatment seekers necessarily. So what we wanted to do was acknowledge that people who use cannabis also use alcohol, and that people who use amphetamines also use alcohol and nicotine, and they may also gamble, and that this is because the causes and underlying features of these type of disorders or these manifestations of problems are actually coming from the same place. So instead of developing a treatment that might only be really relevant for 3 clients on someone's caseload, we wanted a treatment that was flexible, that could respond to a client who is presenting with multiple needs. We included a lot of skills training. The original iteration was really looking at motivational interviewing and relapse prevention and taking elements from those practices and kind of formalising them in a way. But what we found was that there was significant comorbidities around anxiety and depression in the population of people accessing treatment, of course. So we didn't want to just address substance use. We wanted to address depressive tendencies. We wanted to address the cycles of behaviour that people get into when they have depressed mood. We wanted to address anxiety, and we also wanted to address things like anger, difficulties just generally regulating emotions, difficulties in relationships. And so we developed a whole second package which was based on skill building. And the skills-based exercises were very much informed by the dialectical behavioural kind of treatment literature that shows that often a therapeutic relationship is incredibly important and effective, but in the absence of actually teaching new skills or coping skills in some respect, then really it's a missed opportunity for ongoing behaviour change to occur in some respects. We took this session by session, like Ange and I just wrangled with a lot of the funders and a lot of the people working on this project with this rationale of it being modular. We really, really wanted it to be something that clinicians could pick and choose which bits of it they thought from their clinical judgment would be useful for that client. And this comes very strongly from the implementation science literature that shows that clinicians value flexibility over and above everything else, because we really, really want to respond to our individual clients' needs. And a session by session format doesn't allow us to do that. So what happens if we're not able to, conduct our practice in the one thing that we value very highly, which is flexibility, is that we don't adhere to the materials in the first place. And that's the difficulty of implementation fidelity of these type of interventions. So what we did was, instead of trying to force clinicians to do things they didn't want to do, we actually just responded to what happens in usual clinical practice, is that people make an assessment of a client's individual needs and then they decide together with the client on what best is the first thing to approach here, and that a resource needs to be able to be modular and flexible to respond to that. So we kind of won that battle, and it ended up being one of the most important kind of features of the package, I think, the modular package. And then we relied on our evidence-based practices to inform the development of the actual exercises. And that was motivational interviewing and a lot of the cognitive behavioural therapies, because they really are the therapies that have got the most empirical evidence behind them. And we included practice elements from dialectical behavioural therapy, acceptance and commitment therapy, and mindfulness-based relapse prevention. Okay, any questions, queries?
Could you talk about the maps, what they look like?
Sure, absolutely. I'd just like to acknowledge my co-authors on all of the intervention materials. Judy and Angela are both here, and David is obviously, I think he's in the Gold Coast. Anyway, maybe he's back in England, I'm not sure. And so just like to acknowledge them. This is a collaboration across a lot of people and institutions. Covered that, sort of, but we'll talk about the mapping if you like. So there's quite a strong evidence base in the addiction literature around this idea of what is called node link mapping, but really, I mean, clinicians use maps generally to chunk information together for clients as a mnemonic aid, really. But the evidence around it is quite compelling in terms of whether a client leaves the room, and these studies are really cute where they ask the clinician what they perceive to be the core themes of the session, and they ask the client what they perceive to be the core themes of the session. And without aids like mapping, usually they don't really align. So you would know from your own clinical practice when you ask, you know, you're like, I think that was such a terrific session. I really worked on building strengths, and I addressed their ambivalence about change, and I really think that they walked out of there with a clear idea that the main problem is this relationship that they're in. Nothing's changing unless they leave this guy, right? The client walks out going, what was so useful was this one thing you said to me. And it's usually a thing you don't even remember saying. And this is, people do a lot of these studies. And so in some respects, I'm being a bit facetious there, because what is incredibly important is a shared understanding of treatment. And that's why we use all those words like collaborative, therapeutic relationship. It's basically not meaning that the client likes you, although that's important. It's meaning that you both have a shared understanding of what treatment is for, what you're aiming for, where you're going, and why. And so it's interesting if you ask a client that comes to you about what their past treatment experience is, and often you'll say, what kind of things did you work on with that practitioner? And they'll say, I don't really know. And that's a really nice clue that potentially there wasn't a lot of collaboration in that treatment. If they come and say to you, I really needed to work on a lot of my, inability to assert myself, then you've got an idea that really there was a clear treatment goal or a clear treatment direction that the client was sharing in and had an understanding of. And mapping facilitates that basically. And a lot of the research that's been done out of Texas in this particular area is looking at how a clinician and a client can collaborate, and mapping is the tool that facilitates that. Not just collaborate so that they both understand that what is being worked on is a shared understanding, but also what is remembered after the session. And mapping is used in every single field as a mnemonic aid, an aid to help us recall lots of complex information. And so really there's no surprises that this facilitates a shared understanding of treatment, which is actually a weird thing to do, to sit and just talk to someone for an hour. And then you might leave not really knowing what the core parts of that are. So R2C has structured resources so that really, even though it's tailored, even though each individual client will have their needs met in an individual way, that you can be assured that the whole team delivering R2C are consistent in how they respond. So they're informed by the same materials, the same therapeutic underpinnings, and the same evidence base. And that consistency is incredibly important for clients as well. So this is a map, just looking at self-care basically. Attending to self-care is one of the core features of reducing risks of relapse, as well as learning to regulate emotion. And it's a very broad concept, and so in this map it basically chunks all of the different domains of someone's life that they might be able to address in their self-care, rather than just listing all the things they need to do to care for themselves. So this is R2C. And the resources themselves, and at the moment it's delivered here at HealthLink by both an alcohol and drug and gambling team. So the red resources there were developed by Judy and Ange and David and I for gambling, and the blue resources are more addressing alcohol and other drugs. But if you sit those resources side by side, they are almost exactly the same. It's truly a transdiagnostic resource. The difference is that the harm reduction information in the blue resources is particularly pertaining to the risks that you might have if you're engaging in substance use. And just with the opportunity to revise the intervention for gambling, we did expand certain sections which are particularly important for people struggling with a gambling issue around repairing relationships and interpersonal functioning. So these are the resources. The clinician manual is basically how to administer the resources, and it has a troubleshooting section for when they don't go right. And then the resources are mailed to the client. The booklets are mailed to the clients as self-help resources, so that when you're on the telephone working with someone, they have those resources in front of them and you're both working from the same page, so that again, this is a collaborative practice. And it even gets to the point where the clinicians ask the client to, turn to the page so that we're both talking about the same thing. To be honest, it's not used as formally as that either a lot of the time, but it's something which is a resource that the clients can then refer back to if the conversation has been around repairing relationships. Then the clinician will direct the client to that particular extra material, for example, or the client might just have access to this book and they read the self-help materials and they bring up this as an agenda item that they want to talk about in the session. I'm reading through this whole section on controlling impulses, and that is me. I want to talk to you about this. Is another way it might be used. It might be used by the clinicians as a homework exercise. We don't use the word homework, obviously, as a practice exercise, but it might be just a discussion around mood management and realising that someone is quite depressed, and then asking the client to really review some of the mood management strategies between this session and the next session as an additional resource. So I don't know if some of the team are here if they want to chime in about any of the flexibility of the resources, but just acknowledging as well Verity, Anna, Charlotte and Ravi. Ravi's not here, Anna's not here, but this is the R2C team here at HealthLink who are delivering the program at the moment. This is just a snapshot from the clinician resources, which really outlines what it is and what it's based on. I've kind of covered all that. The background knowledge required to deliver R2C is really just really good micro-counselling skills and probably not a bad knowledge of motivational interviewing and relapse prevention. But really there's no assumed knowledge around dialectical behavioural therapy or ACT or any of those more formal therapies. Because it's a translational tool, we've taken a lot of those practice elements and written them as if you didn't have to translate it for the client into something that you want to deliver. So the assumed knowledge is just being a good counsellor. So there's a lot of resources in R2C, so we've written quite a bit around how to navigate your way around R2C. And one of the things that was a bit of a problem from a research point of view, because we were interested in evaluating this, was the flexibility of the resources. And so a compromise between the research agenda on this particular project and the clinical and service delivery agenda was what we called the Fundamental 4, which are 4 exercises that regardless of presentation everybody gets. That's the idea. So that these, the Fundamental 4 we chose as kind of like the core behaviour change strategies that are used across all cognitive behavioural therapies, regardless of the disorder, that are associated with long-term behaviour change. So everybody gets the Fundamental 4. Then based on the reason why someone's presenting, so for example, a common reason why someone might ring for assistance or walk into a service for assistance is that they themselves have ceased their substance of abuse and they want assistance in maintaining abstinence, and they'd like assistance with relapse prevention. Not that they would say that, but they come in seeking help after they have already ceased treatment themselves. Now there's a lot of evidence in the literature around motivational interviewing that to then work with someone at that stage of readiness around their motivation to change is actually sending them backwards. Instead of working with them on motivation, you want to work with them on relapse prevention. And so this was another rationale as to why this resource had to be modular, because people present after different episodes. So if they've recently stopped using and they need support to maintain change, then you wouldn't bother doing the first few sections of R2C. You would go straight to the relapse prevention modules. which very much look at building resilience to relapse. Alternatively, someone might present who's currently using and needing support and contemplating that they might be wanting to stop, or that they're coerced into attending treatment through a family member or the court system, or they themselves are just unhappy about the level of their substance use and they would like to reduce it. And so for someone presenting with this particular issue, then we have the first series of modules which are around building motivation to change. And then setting goals that people will achieve. This is really motivational interviewing translated into practice, as well as goal setting. The other thing that we've included in that particular section for people who are currently using is specific harm reduction information associated with cannabis, amphetamine and alcohol. So we're really acknowledging that this is a harm reduction package as well. So the fundamental four is firstly what we would call a cognitive behavioural functional assessment of substance use, which looks at not why someone started using substances, but what features maintain their substance use. And this is the basis of most cognitive and behavioural interventions about addressing the maintaining factors of substance use. And this is based on a lot of our learning theories about why people continue to use substances in spite of the harms. So they look at, I don't know if anyone would have obviously done these sort of formulations, but they look at, this map looks at modulating factors, it looks at maintaining factors, both internal as in mood related and external as in situational. And it looks at the consequences of the substance use, which then obviously have a further feedback loop into maintaining substance use. So it's a picture of how someone's substance use is maintained. This particular map then is what very much informs which skills you might then address. So if the internal triggers identified in this are around anger and frustration, there is a module in our skills package around managing anger. If the internal triggers are around thinking traps, like I feel sad, I feel hopeless, nothing I do makes any difference, then there's a module in the skills package around enhancing mood. If the external triggers are about hanging out on your own at home and not having meaningful relationships with people, then there's a skills package about cultivating relationships. So it's a little bit of a clue already from the first assessment of which skills you would offer this client from a formulation point of view, which is very individual for each client. Then we do a self-monitoring exercise. This is varied in terms of how well people adhere to these type of exercises. But the evidence around self-monitoring is so compelling that we really can't avoid including anything that encourages people to monitor a behaviour that is now somewhat automatic and habitual, because it really asks people to attend to, in a day-to-day fashion, something that they're trying to change. So the self-monitoring is one of the fundamental four. We've got managing urges with sober breathing, which is a mindfulness-based relapse prevention strategy to manage urges. And obviously that applies to any substance or gambling. And that's the map and the psychoeducation sheet on sober breathing, which again is an acronym used so that people can remind themselves to engage in this particular practice when they are feeling an urge or a craving to use. So you probably can't read it, but SOBER stands for stop, observe, breathe, expand your awareness, and to respond mindfully to the urge or the craving. Then we've got establishing a helpful routine, and in all behaviour change literature, meaningful routines are at the core of maintaining good behaviour change. They're at the core of managing mood, managing anxiety, and they're really good for our well-being and our psychological health. So we've got a helpful routine planner so that people can structure their week. This is based on the cognitive behavioural literature around pleasant event scheduling, as well as mastery, and really just common sense about filling your day with things that aren't substance related, I guess, or gambling related. So we then have a section on motivational interviewing. So some colleagues from Deakin, Ange Petra and I from Deakin, David from Sheffield Hallam University, and Dan from Monash have written a paper which was a systematic review. It took us 2 years to do. I need to let that go and move on, but it's still recent. But what we did, we looked at how well people learn motivational interviewing in terms of the dissemination of this practice, and how easy it is to implement motivational interviewing to a point where clinicians develop enough proficiency in this method in order to effect change within their clients. So like any kind of clinical practice, you can do little bibs and bobs of it here and there, but most of the empirical literature means that you have to acquire a level of proficiency in the particular practice in order to be able to then extrapolate that what you're doing is evidence-based. This comes back again to the issue around implementation fidelity. So if we say I'm doing motivational interviewing, but not enough to mirror what has occurred within the clinical trials of motivational interviewing, then we aren't doing evidence-based practice, even if we're doing a little bit of it, because it's not a saturation effect in order to impact client outcomes. So we wrote this paper on this, and we worked out that it's very, very difficult to learn how to do motivational interviewing to a point of proficiency that we would suggest would impact client outcomes. And this might take several years of not just training, but ongoing coaching and ongoing feedback about your skills in a client session, which would mean having your session observed and then having someone rate the fidelity with which you have delivered motivational interviewing. So these studies are really big randomised controlled trials of a number of clinicians who receive training, who receive months and months and months of ongoing coaching and feedback around formal kind of fidelity tools for motivational interviewing. These are the studies that we reviewed in this paper. And the red line across this graph is what we perceived to be the percentage of clinicians who reached proficiency that would warrant a service undergoing this training. And we set that benchmark at 75% of training participants reaching what's called beginning proficiency, which is the same level that people use in clinical trials of motivational interviewing. So we could assume that this is the level of proficiency you need to reach in order to impact clients. So you can see there that not a lot of these really large implementation studies actually reached that level, and that in actual fact most of them are a lot lower than what you would expect after undergoing that amount of training. So this is using what is like a standardised outcome measure of adherence to motivational interviewing, which is called the MITI, as a validated sort of tool. Similarly, if you use the same type of scale, which is called the MISC, which looks at how well you adhere to motivational interviewing, you can see that still when we benchmarked 75% of training participants meeting this criteria of beginning proficiency, not a lot of these studies actually reached that. None did. So from this kind of literature, we were writing this review at the same time that we were writing Ready to Change. And so it really informed how Ange and I were trying to present the motivational interviewing elements in Ready to Change, because it was becoming really apparent that it's quite hard to learn how to do motivational interviewing based on those core concepts of the conversational style of MI. So we kind of changed the way we then presented MI in the package. We were looking at a lot of the literature that showed that if you just deliver MI and you, from a structured point of view, you don't have as good outcomes if you just train a clinician in the spirit of MI and then they use their own judgment of how to respond to a client. So it seems that there was nuanced decision making in how you use MI that was really impacting its effectiveness. So we've kind of done a little cheat sheet really to help clinicians make those choices based on the empirical literature of MI. So what we did was look at developing exercises for people who had high motivation and high confidence. This is someone who rocks in and says, I've made the commitment that I'm going to change my alcohol use and my gambling. I've given up smoking cannabis once before, as well as I've come back from a serious motorcycle accident. I'm pretty confident I can do it. I've got a lot of strengths, and I just need assistance in that. High confidence, high motivation. Now, if you talk to this person as if they are someone with low confidence and high motivation, it actually is not a very appropriate exchange for them. So you start working on their strengths or their motivation, for example. So what it sounds like to me is that, you know, this is a very important change that you want to make. Yeah, that's why I'm here. So it sounds as though if I gave you a scale of 1 to 10 about how confident you are to achieve this change, where, you know, 10 is your most confident and 0 is not that confident, where would you rate yourself? I said, I'm really confident, I'm 10, you know? Let's get on with it. What do I do? I need you to tell me how I get this working. So what you're saying is that you're ready to change, you know, and it just drives people insane if this is the type of exchange that they have when they're at this high confidence, high motivation stage, even though that is appropriate motivational interviewing techniques, but not for this guy. So for this guy, you go straight to the change plan, which is an action plan about what needs to happen that week for him in order to make some serious and significant changes. So it assumes that motivation's okay and confidence is okay. Now, if that guy presented for treatment all the time, then that'd be terrific, but he doesn't. Usually we might get someone who has low motivation and low confidence. Historically, these were called pre-contemplators in that transactional model of change, which we don't use in R2C at all because it doesn't have a terrific evidence base in predicting behaviour change. Even though it might be interesting conceptually, it's not something that then informs how you should respond to someone. It's far more nuanced than that. As good counsellors know, it's far more nuanced than that. So this low motivation, low confidence guy rocks up, and we have exercises 1, 2, 4 and 6 that are for this guy. So exercise 1 is working out what you want. And it's a question, what change do you want to make to your substance use? And what we took to create these exercises are the training packages that Miller and his colleagues disseminate as part of their training network. And we were really informed by the questions that they train people in asking, and we then specifically included those questions in this package. Instead of like the very general sense of rolling with resistance, which is very hard to translate into practice without a lot of coaching and without a lot of training really. Building self-efficacy. You know, that's a very hard concept to then put into really concrete terms. So we took a lot of these questions, we took a lot of the scales. So question 2, what are the 3 best reasons for you making the change? I know everyone who's done motivational interviewing training has done these type of exercises, but rarely do we just get this direct with clients. And then question 3, on a scale of 1 to 10, circle how important it is for you to make this change. And then you want them to circle the reason that's most meaningful to you, from question 2, so that it's really in their mind, the most important reason. One of the most important concepts in motivational interviewing is not giving advice, not stepping in too quickly and advising someone on what they need to do. One of the most important concepts is listen. You talk less than your client. And that's what some of those rating scales actually rate, whether you give advice. You get a little cross, whether you talk more, the ratio of how much you talk versus your client. If you're talking more than them, you're not doing motivational interviewing. So we ask really, we're interested in the client's reasons for change, even though it might appear that they're there because their wife said they might leave them. unless they change. And we've all been in a situation when in actual fact that's the bonus. They're hoping the wife leaves them. And in actual fact they're so unhappy that that's the reason why they keep drinking. So to assume that they're accessing treatment because they don't want the relationship to fail is not really listening to the client, even though you could make that assumption. Then question 4, why did you choose whatever number and not 0? And then if you were to change, what would it be like? You know, just imagine what it would be like. And these are the type of questions we ask. Being clear about your reasons for change is another question that we ask them. Rarely would the clinicians do this formally in terms of we give these resources to skilled counsellors. The team are all very skilled counsellors. They don't fire these questions at people. They don't say, what are your reasons for change? Give me the top 3 reasons. But what it is a structured way of ensuring that the core parts of motivational interviewing are included in a conversation or as part of a worksheet or as practice exercises. So I'll flick through this now. So this is motivation and confidence, and this is something of where I am now versus where I'd like to be in 3 months' time. And these are the core kind of exercises that we engage in to try and build motivation for people to make a change. There's the change plan. Then if they're low on confidence, we have significant sort of areas of the package which are about building self-efficacy, which is one of the core features of motivation interviewing. But we're very sort of clear about what are your strengths. We wouldn't say this exercise is about building your self-efficacy. We're very much about what have you been good at in the past, where are your strengths, and being really explicit about that with someone. And if they can't really think of their strengths, which occurs in people with very low confidence, then we even prompt them and we facilitate this kind of way of trying to discern strengths. And then they would map them out so that they can recall what their strengths are. And then we've got relapse prevention, which again we translated into MAPS, about dealing with urges and cravings. This is a cognitive behavioural intervention. Relapse prevention is basically CBT amended for addiction, and we've basically really made it far more nuanced than just what are your high risk situations, which can occur when you're kind of fitting relapse prevention into a really busy session. Then at least these materials are there to look at both internal triggers for relapse and the management of those as well. So internal triggers such as thoughts or feelings or emotions then can relate again back to the skills-based modules, so that people start feeling that they just have a little bit of insight into what their vulnerabilities are for relapse, but that instead of just knowing that when you have a low mood you're at risk of relapse, you have resources available to you to improve your mood, because we don't want to give people that information and then not have a way of resolving it. Okay, so we've only got 5 more minutes really. So these are the skills training modules, which are a separate booklet that I've alluded to throughout, that are informed by this particular map I spoke about. We have managing anger, which is really looking again at cognitive behavioural interventions for anger. We have an anger control plan, which is quite specific and detailed and action orientated. We have a lot of mindfulness-based exercises throughout Ready to Change, because we really were informed by the third wave cognitive therapies of DBT and ACT and mindfulness-based relapse prevention. So mindfulness is really a core skill across all of the modules. So we've got a mindful walking exercise and then a 3-minute sort of breathing exercise as well to try and teach people mindfulness skills. Now, just in the last few minutes, I'd just like to acknowledge another pilot of the R2C that's been conducted, led by Vic, who's sitting here. And again, it's a collaboration across a lot of other institutions, but Vic and her team have done a pilot evaluation of R2C over the telephone. And from this particular evaluation, really again, it's a pilot in order to examine some of the effectiveness of R2C, looking at psychological distress as well as AOD use. We also just wanted to look at whether these materials are still feasible, whether they're acceptable to clients, and the level of engagement that the clients had with the treatment and the clinicians working with them. So Vic and her team looked at 23 clients who accessed R2C through Direct Line and who were allocated to the R2C team members, to either Verity, Anna, Ravi or Charlotte. And the outcome measures are very, very similar to the very first intervention that we evaluated. Looking at the audit, we included the DUDIT and then the Kessler. Now the TCU scales we also included in the very first evaluation pilot, which is really looking at treatment motivation, that really diffuse notion of a collaborative therapeutic rapport. And so we also wanted to measure those less tangible features of the intervention. And obviously the participants went through an ethics process as well as their 6 sessions of R2C and then a post-intervention assessment and a 3-month follow-up. So the pleasing sort of outcomes of this study are looking at significant reductions from baseline to 3-month follow-up in the core areas that we were assessing. Again, it's a pilot, and as part of this pilot data, Vic, myself and a group of other researchers have put in a grant for a more robust evaluation of R2C delivered over the telephone, just to determine, we think now that there's enough evidence to show that this warrants a really robust evaluation of its effectiveness to be delivered over the phone. And we think at this stage there's good indications that it's a really good contribution to our treatment system of having this phone delivered treatment for people who wouldn't otherwise access treatment or prefer to access treatment on the phone. And then the other lovely thing about the outcomes of the evaluation conducted is the levels of satisfaction and counsellor rapport measured through the TCU scales. And they're showing that R2C is equitable, if not more acceptable than face-to-face treatment. And I think a lot of people, the literature on telehealth very much indicates that telephone delivered treatment is as effective as face-to-face, but I think that there's a lot of clinical assumptions made that in some way it's a less rich therapeutic environment for a client to access because it's not a face-to-face relationship. And in actual fact, the team are demonstrating that that's not what this evidence is showing, that this pilot is showing that it's an incredibly effective therapeutic engagement and rapport, and in actual fact that there's no indication that it's a poorer environment to establish a therapeutic relationship with a client, which is really, really exciting. Okay, so obviously the analysis is that these changes were significant. And that it really does warrant a more robust evaluation now. Okay, so if you're interested in referring any of your clients to R2C, call Direct Line, and then that's all I have to mention now, but I'm happy to take questions. I know we're right at the end of time, but if you want to ask me something after the end of this, I'm happy to answer.